So welcome everyone, and so this is the third day of FedEx. You all deserve a round of applause for being here. So thank you. All right. For those who are not here, they're gonna miss out. So welcome. My name is Alice Wong. I'm the founder of the Disability Visibility Project, which is an online community dedicated to creating, sharing, and amplifying disability media and culture. So the phrase access to healthcare is a familiar one used in media, medical journals, and activism. Access to healthcare can mean something different depending on the community or population. For instance, some people with disabilities may have access to healthcare, such as a great insurance plan, but the care they actually receive is inaccessible to them. So today we're going to dig into that because this is a panel called Interrogating Accessible Healthcare. I'm delighted to have this stellar panel of disabled people, and I think you're in for a real treat. So we're going to go ahead and start off. I'm going to ask the panelists to introduce themselves, starting to my left with Mary Lou.
Hi, everybody. My name is Mary Lou Breslin. I'm a senior analyst with Disability Rights Education and Defense Fund. We're a law and policy organization in the San Francisco Bay Area and Washington, D.C., and I'm thrilled to be here today and so happy to see so many of you here. Thanks for coming.
Hi, I'm Robin Wilson-Benson, and I am a disability and sexuality educator and writer, and I am based here in the Bay Area. And I taught my specialty, my area of interest is reproductive health care and disability. And you can find me on Twitter at sexabled and www.sexabledwithrobinwb.com. Thank you.
Hi, my name is Ryan Easterly. I serve as Executive Director of the WITH Foundation. We are a private foundation that promotes the establishment of accessible healthcare that meets the needs of people with developmental disabilities. We are a national funder, but we're headquartered in Palo Alto.
Great. And I think just to start with a really broad question is just to give the audience a sense of the healthcare landscape for people with disabilities. I'd like to ask all of you, what are some of the major difficulties and barriers people with disabilities face in healthcare? What are some of the major access issues that concern you the most? And anybody can start.
For me, particularly in the realm of education that I found and how I got here, was the attitudes, expectations, and assumptions of people with disabilities and what they would be interested in or capable of doing sexuality-wise, and basing their assumptions of sexuality on heteronormative ideals, and especially when it comes to the conversation of people with developmental disabilities. And I find that attitude, that is one of the greatest barriers in changing because we're all products of culture, and working with those attitudes and working with medical professionals to embrace that, people express their sexuality in various different ways, and getting them to think out of the box that way.
Great. Mary Lou?
Well, I think it's helpful actually to step back just a little bit because that question is really complicated and big. And I think it's useful to sort of keep in mind that both clinical professionals and public health professionals focused on cure and prevention of disability really up to extremely recently, as little as 15 years ago. The idea that people with disabilities had separate and different healthcare access and healthcare outcome issues is kind of a new idea. And the idea that people with disabilities experience pretty significant health disparities and health care disparities is also a new idea that has shifted the way we're thinking about the treatment of people with various kinds of physical impairments and limitations. That shift has really resulted in some sort of seminal research work that's been done by the Institute of Medicine, the National Council on Disability, the Surgeon General, and others that really have begun to identify the fact that people with disabilities experience disparities, and the reasons for those disparities are complex and interrelated. But some of the barriers that Alice is asking us about today have been identified in that research and other research. And honestly, the top of the list of problems is the one that was just mentioned. The problem that we're facing with sort of the educational opportunities for professionals in the field is really quite legion. There is very little being offered. People come out of various kinds of medical training programs with almost no orientation to disability literacy, and it results in very serious problems at the clinical level. And unfortunately, practitioners are subject to the same kinds of biases and stereotypes that the general public is in terms of disability. I recently saw my dermatologist, who's a new person for me to see, and she walked in the office and looked at me and said, "What's wrong with you?" This was a month ago. And I didn't know if she was referring to my bad attitude, which was possible.
Because you do have a bad attitude. You're a bad.
Immediately had a bad attitude.
You're a bad lady.
And so I explained, as carefully as I could, what my disability is and what it meant, although it had nothing to do with why I was there for my dermatology appointment. And then she sat down in her chair and she said, "I'm so sorry." And I tell you that only because that really represents sort of the underlying kind of pity and fear and lack of appreciation for the active lives that many of us lead. It's very pervasive in the profession. So I think that's the number one barrier. The second barrier is the lack of individualized accommodations in the clinical settings. Accessible weight scales, accessible examination tables, accessible mammography equipment, and other kinds of individualized accommodations. The third big issue, I think, is a complex, interactive set of social determinants that we're very familiar with in other areas: poverty, lack of transportation, lack of proper coverage and insurance, or adequate coverage, and all of those interact in very complicated ways. So those would be my top issues.
Thank you, Mary Lou. We'll definitely dig into that. How about you, Ryan?
From my perspective, in my work and in conversations with friends and my personal experience with medical professionals, finding access to professionals that understand aging and disability. Oftentimes we see pediatric professionals that have a specialty in disability, but what happens when they become an adult or reach their 40s through 60s? Do people with disabilities have the same access to medical professionals that understand what it's like to age with a disability? Also, as Mary Lou touched on, access to medical professionals in rural areas. This is an issue that doesn't just affect the disability community, but is hard to resolve and meet the challenge of transportation and accessing medical professionals, especially if you need disability expertise if you live in a rural area. Think about if you have to travel 4 or 5 hours, what that does to your body, what that does to the amount of work that you have to put in to see, someone just to say, is this a disability problem or is this the flu? So access to medical professionals in rural areas. Also, something the foundation is working on is we are currently in the midst of a transition in the healthcare field, and we see a lot of activity in the digital health space. So for the companies and the developers that are operating in digital health, as they're developing and innovating products and services, having them understand that the disability community is part of their user base as well. And then lastly, I feel like I'd be remiss if I didn't mention access to dental health for people with developmental disabilities is critical.
And what are some of the issues that are particular to adults with developmental and intellectual disabilities that they face that, let's say, the audience may or may not know about in terms of the barriers they face? Since the WITH Foundation does to provide a lot of different projects and grants that really address these barriers, what are some kind of, general kind of issues?
Well, as I referenced and Mary Lou referenced, transportation is a big issue, as well as general understanding of disability services and connecting issues. So when a person with a disability comes into a doctor's office, sometimes it is related to their disability, but sometimes it can also cross into a housing issue if there's mold in their house that's presenting, other health issues. So helping professionals understand and be aware of resources that have an impact on their health, but aren't necessarily medically directly related.
And Robert, earlier today, you just gave a talk to a bunch of folks about sexuality. So why don't you tell us a little bit about that?
What I today earlier I was talking about addressing the needs of comprehensive sexuality education for developmental disabilities, and I was especially talking about medically fragile, but also we were talking about populations that people see as quote unquote vulnerable. So we were talking a lot about developmental disability and sexuality, but particularly I was following what medical professionals have been doing in other countries, because disability is, it's a human condition, so therefore it's global. And the things that other researchers and professionals are developing, such as books. For instance, in Sweden, they came out with a set of books to explain it, and illustrations, but also very clear, simple vernacular, where there's no misunderstanding about what they're talking about, and not in big clinical language, but so it's accessible, and so it's something that it's medically accurate, but it's accessible, and thinking outside the box, right, that I'm seeing a need. I think that would be really great would be for apps, because an app or something to work, especially like for nonverbal, to communicate about different medical issues related to sexuality. But we're talking about also when you were talking about education from. It's so broad when it's coming to sexuality education, but talking about everything from, childhood sexual education, but also adults, dating, relationships, all of that, but as you're aging as well. And I find that there's all these kind of intersections between, because everything is related. And I recently developed a curriculum for the Unitarian Universalist Church on sexuality and aging and disability as your body changes. But in those things are issues to talk about too, with how to address have these conversations with your doctor, and how to talk about how your conditions affect things that you need to get to where you need to go.
Yeah, I feel like it's talking about sexuality. I think one of the things that you mentioned about these attitudes,
Yeah,
is that it's still very true. You guys might be surprised in this audience, but so many people with disabilities who want to have children, they are constantly surprised by doctors who say what, you want children?
yeah.
How does that happen? Or it's too dangerous, or that.
How are you going to take care of it?
How do you take care of it? Or Do you have sex? So these are some major, like, cultural issues that we won't be able to solve today. But these are really, real impacts on the way people see people with disabilities and just not afford them the same kind of considerations as non-disabled patients. So what are some of the other kind of attitudes and, I guess, stereotypes that maybe either you guys have experienced or have known about, that's very pervasive in the disability community in terms of just the ableism and the stereotypes and all that stuff? Anyone?
Well, I can tell a quick story.
Yeah, we all got
might
stories.
illustrate that question.
Yeah.
I was treated for breast cancer about 13 years ago, and honestly, dealing with disability issues in the context of breast cancer is the big deal. It's not the breast cancer treatment. I went for my workup for the chemo plan and met with the outpatient chemo nurse and staff and so on. And we were developing the plan, and as she spoke with me, she said, well, you're not going to be able to be treated in this unit. This is the walk-in unit for infusion care. And I was a little confused by that conversation, and she said, well, because this is an ambulatory unit and you're not ambulatory, you'll have to. I have a couple of oh my gods from the audience, which I always appreciate with this story.
Yes.
But I think that in kind of rigidity and confusion about how disability works, particularly for people who are actively engaged in their communities and have families and so on, and the disability is the sort of secondary to many other issues for many people in terms of living their lives. This was really a surprise, and of course, it was very fortunate that I was working for a law center because our directing attorney was right on the phone and called in and basically said, you can't do that. First of all, it's discriminatory. I was being told I would have to be admitted to the hospital for what is essentially routine outpatient care, and that unit's much more qualified than any inpatient staff to deal with the issues. So that issue was reversed, but it was one of many hurdles that I think all of us have experienced in different ways in dealing with our clinicians. And quite honestly, I'm almost 73, and I've been dealing with this for a long time. Yeah. And pretty much any new doctor I see, I have to train to deal with my disability and to understand its implications and to separate the disability issues from what I am presenting and to determine whether they're related or not related. Sometimes they are, mostly they're not, and to figure out what the appropriate course of treatment is going to be. And if I didn't know how to treat myself, I think I would be getting poor care simply because my clinicians are not able to understand what I need and how best to deliver the care that I need.
I can talk, using stories, how I got into, for instance, in my career, it was because I got pregnant with my daughter at the same time I got a spinal cord injury. So I had a AVM in my spinal cord, and it was starting to rupture. And so I had surgery at Emory to remove it. But I found out a week before the surgery that I was pregnant with my daughter. And so the course of that taught me a lot. It was a hands on the ground teaching about what the medical profession and the attitudes and what they could do, or the attitudes towards pregnancy. And so I am with my disability, I am an incomplete quadriplegic, but I was in a rehab center while learning to use my body again. But during the course of my pregnancy, during my first and second trimester, and right up to my third trimester, and they were really unprepared, actually, at the rehab center. But they were absolutely fabulous. It was a spinal cord rehabilitation hospital, and they were amazing because that's how, to me, that's the only way I got through that pregnancy, was because this place was like, okay, we haven't had a patient that has been pregnant in this unit, but we'll figure it out and we'll work. And having those therapists and both the physical therapists and the occupational therapists and doctors that were willing to work with me. And even though it was something that they were unfamiliar with, they, working on solutions. And then that's how I found, for me, that was how I found that, you could have successful outcomes. I did get, but I also encountered a lot of the bad attitudes. Like when I was pregnant and I was being admitted to the rehab center after I'd had the surgery, there was this much older white gentleman. And the reason why I mentioned it is because there's also, race also impacts too, so it's how you receive care. Again, so he sees me, and I'm presenting typical quadriplegia. I'm not able to sit up or do anything, and I'm pregnant. And he was like, "You're pregnant?" He goes, "Why didn't you, and you knew you were going to be," he goes, "Why did you not use birth control if you knew you were going to be like this?" Yeah. And that was the admitting doctor that was there that evening. And that was, and I was very, very weak because I had, here I was pregnant. I had, 3 weeks prior, I had three different operations on, to remove the AVN and to heal it and, to sew it back up and, hope for the best before they sent me to rehab. But I just remember going, yeah, no, that's not cool. That nobody should have to hear something like that. And it's more than just hearing, but I'm going, wait, whoa, what about my agency? What about, the agency as a human being? So you're saying that because I am like this, then I'm, but the whole birth control, but yeah, so that's where, dealing with it, but that's when I found, but if you have physicians and you have people, you have medical people who are willing to work with you and work with the patient, you can have some really great outcomes. And that's when I've been able to get an amazing continuum of care, and which is why I stuck with Shepherd Center and that's where I did my rehab and kept trying to find different I wish I could have gone there for all of my care, for everything, because, they were equipped to work with disability and realize that we're all unique.
As far as my perspective, I find it interesting, especially working in the healthcare space, and kind of having all the labels that I have, being a foster kid, a person of color, a gay man, having a disability, all those lovely labels.
Yeah.
That I was 25 before a doctor actually asked me if I was sexually active. Mm-hmm. I'm a survivor of sexual violence, and I had gone through court proceedings about it, but I had never had a doctor actually ask me, "Are you sexually active?" until I was mid-20s. So I think, why, out of all the medical professionals I saw and have seen, why is that not okay to ask me? Mm-hmm. So, and, I think the people I come across tend to be more in the know, but that still happened. Mm-hmm. And then I think about issues related to access to paperwork. For me, I write slower. Some of it's related to my disability. Some of it's just I'm a perfectionist and want to make sure people can read my handwriting. So making sure that if you're going to have me do intake forms, can you email them to me prior to, or somehow get them to me beforehand so I don't have to spend an hour filling everything out. And oftentimes I help younger people that I know with disabilities navigate different healthcare processes. And most of the time that is a request to me that's easy that a lot of doctor offices don't think about. Instead of thinking, well, they're not going to be able to give me this paperwork, just send it to them beforehand. Oftentimes appointments are made 2 weeks, a month, 3 months in advance. Just put it in the mail. They can work with their existing support systems to get the paperwork filled out. And then another thing around attitudinal barriers is the understanding of guardianship and supported decision making for people with developmental disabilities. Oftentimes there's kind of the preset for medical professionals to defer to the authority figure in the room. So look anywhere but the person with a disability. And even if an individual is under guardianship or conservatorship, if they are of adult age, you should still be involving them in the process. You should still direct questions to them, despite their guardianship status. So,
Yeah, people think that people with disabilities who don't speak somehow don't have a say in what they want. And I think there's just so many kind of these kind of assumptions, and or the sense that people are deaf. People constantly ask deaf patients, "Oh, can your relative interpret?" Which is so inappropriate. There's so many instances where, I think a lot of clinicians and office staff think, we can make do with this, or can your relative help you get on the exam table versus their legal obligation to provide access. And also, I think that there's another thing where, some people with disabilities are going to take a little bit longer than that 15-minute slot that most, primary care, you're lucky to get 15 minutes. But sometimes that may take about 10 of those minutes, maybe getting in the room and getting your vitals and getting all that. I mean, for me, I think it's really interesting as a wheelchair user that I've had primary care doctors in the past where to get weighed, I would have to go to another clinic within the same building because there was only one accessible weight scale. And to me, that just doesn't seem like integrated care. It doesn't seem like access, and it just feels like there's something wrong when I have to go to another completely separate clinic to do that. And I've actually also had times where weight loss is a real issue for me, and I had to really monitor it. And it's been such a hassle that I actually, did not get weighed for many years because of that. And these are these really, basic things that I think most non-disabled folks take for granted. There is a huge kind of amount of labor that disabled people have to do in terms of just requesting, educating, just making time. There's a lot of labor
And researching.
and research.
I have to, a lot of times, sometimes I've realized before doctor appointments, which, when you were talking about having to do that additional labor, but I have to, I know everybody's like, oh, the internet makes everybody thinks they're a doctor, but no. But I do have, finding studies and things like that to help get to the bottom of what some of my healthcare needs are. For instance, I had a medical device in my body that I had a baclofen pump to put baclofen into my spinal cord. And I lost 100 pounds through gastric sleeve surgery, which made the tubing inside, it made it buckle up on itself and stuff. So I was either not getting a medicine or I would get too much. And so I was having to go to the hospital. I was having to go to the ER. I got either an underdose or overdose, but whatever, something happened and it was horrible. But it took me bringing in piles of research to my doctor, trying to figure out what was going on, and reading everything I could about baclofen pump malfunctions before I was like, hey, I found someone else that they lost a lot of weight, and this is what the issue is. But that was additional work I had to do, and it wasn't like it was quick. It took me months to find that, and I don't.
And oftentimes doctors don't believe.
Yeah, that's the other thing
That's
too.
what
They're like,
so-
we're the doctor. We're the one in school. So.
Yeah.
Can I just jump in and say that
Please.
one of the issues that's really kind of critical is the systemic issues about these kinds of access problems that you guys are talking about. I think we know that just about 90% of healthcare is delivered in basically the offices of healthcare providers, not in huge clinics, not in hospital settings, but in the 2 or 3 or 4 person practice offices. And those operations sort of look like corner grocery stores in terms of they're LLCs, they're small operations, they're not necessarily aligned with bigger entities that can provide resources, and yet we're expecting to be able to go into those offices and have a certain level of cultural awareness, accommodation to the various needs that we have. And the real challenge is how do we find ways to incentivize, to make it possible for those facilities and those small operations to be able to accommodate our needs. And these are primary care kind of facilities. One of the most kind of interesting pieces of information that has come out of some recent research that my organization has been doing is we've been looking at accessibility, architectural, and what we call programmatic accessibility. That's table scales, communication accessibility features like provision of sign language interpreters or materials and formats that would be accessible to someone with a vision disability or additional exam time, as other people have mentioned. And the research that we have done collecting existing data in California indicates that about 81% of over 3,500 primary care practices in the state that are operating under the Medicaid managed care program do not have height adjustable examination tables. So anybody has a mobility disability, a senior who's got difficulty sort of crawling up onto the standard height exam table, either won't be examined or will be at risk if they have to be assisted in some unsafe way to get onto the table. Similarly, about 81% of those practices do not have any kind of wheelchair accessible weight scale. And that is not just for folks who use mobility devices, but for people who can't climb onto the little platform in the regular scale. Yeah. So it's typically people with those kinds of limitations are simply not going to get weighed or get examined appropriately. My provider, which is a very, very large HMO in Northern California, there was litigation involved against them a number of years ago, which resulted in a lot of revisions in their physical plant. And in fact, they did put weight scales in all of their clinics. The last time I visited my clinic, 6 months ago, the person who worked there asked me, she said, "You don't want to be weighed, do you?" Which is pretty much what they always say. Yeah. And I said, "Yeah, there's a scale there. Let's do it." You know, I mean, I know what I weigh, but let's do it because it's the right thing to do. It needs to go on the record. So we look at the scale, and the scale's mounted in an alcove. It's bolted to the wall, mounted in an alcove. So neither end of the scale with the little ramps that go up can be accessed. So I didn't realize it was mounted to the wall, so I go over and I'm pulling on it because you can move the thing out. It's portable. Except it's not. It was bolted to the wall. So I mean, we have really systemic problems in terms of trying to solve some of these both attitudinal and practical issues that have to do with kind of fundamental patient care. And there are solutions in the works. I think there's some real good models that are coming out, but we're a long way from seeing these cultural competencies and capacities sort of being in place for the disability community.
So let's talk about training, and since we're here at the med school, what kind of training do you think doctors, or the doctors of the future, should have and would like to have? Because I do think that, I think every med school now has, cultural competency as part of their curricula, but they probably, I bet you anything, don't include people with disabilities within that broader idea of diverse populations, because I think we're still very much this medical model says that people with disabilities are based on their diagnosis rather than this very distinct population that has civil rights protections. And, really, that would be one of my wish lists is that, every med school would institute, within their cultural competency curricula to include people with disabilities who are the most intersectional, the most diverse populations ever. So that would be one of my top wish lists. But what about you three? In terms of how would you like med students educated on people with disabilities?
One thing because it's something that I felt was important, but because I started doing sex education grassroots, and one of the things I did was I would go to Emory, the first year med students, and talk about taking the sexual health history of people with disabilities, but basically more talking about cultural competency and talking about, working around eliminating, biases and assumptions about people with disability and their sexuality. But I'm realizing that that's something also that I'm working on now, because now I'm working on a book on reproductive health care issues and disability, where it's an anthology with different stories from around the world, so different people sharing their experiences, so that the medical profession can learn from those experiences. But more than that, but just basic things, some of just really, really basic things, even talking about accessible, one of the, training and talking to doctors. I wrote an article for Bedsider talking about different things you should think about when birth control and disability, because not all birth control can work for all bodies. And some disabilities make it to where there are some forms of birth control that you probably shouldn't think about using. Like, for instance, I talked about the pill and blood clots, and if you're sitting down all of the time, then perhaps the birth control pill is maybe not an option, and you should think about another option, like an IUD or something with a different form of hormones to use. And there's a whole bunch of other things, but that's one thing. This topic is so broad, but my thing is that's one way that I think working on basically the cultural competency of the assumption, eliminating assumptions and biases, like that's one form of training. But
Thank you, Brian.
I would say for me, again, it's a very broad topic, but the intersectionality perspective. So especially among primary care providers, having them come in the room with an understanding that individuals with disabilities have multiple identities and multiple areas around their medical needs. So just kind of, for me, I look forward to the day where individuals like myself and individuals with intellectual and developmental disabilities get asked about their sexual health, get asked about the different ways they identify, if they have questions related to particular issues. So often when I come in the room, it's, oh, this is going to be a cerebral palsy question. My medical questions aren't always about cerebral palsy. So just having medical professionals understand that. And then I think in a perfect world, I'd also like to see the medical professionals that do provide services to people with disabilities well share the experience. Help us evangelize. Help convince your colleagues that the disability community is not a big, scary community, that you're able to provide services to your clients in a meaningful way that makes a difference in their life, and they should consider doing it too.
I mean, there's so many amazing activists and advocates like these three folks here in front of you who should be really utilized. I mean, it's really kind of sad that there's such siloed, there's like medical professionals and then there's like the disability community. And that's really not true, because there are a lot of overlaps. Yeah, one of my personal things that I wish would happen was that I really wish there were more disabled students in the health sciences. I mean, that's a whole other topic that we could spend hours on. But I think if we had a more diverse workforce of healthcare providers, that would make a huge difference. How about you, Mary Lee? What's your top wish in terms of medical education or health science?
Well, I'd really like to see some standardized competencies designed. And there's a couple of groups that have been working on this quite seriously for the last couple of years, one out of Vanderbilt University, a group of nurses, actually, who have banded together with colleagues around the country, and they're developing these kinds of standards. And I think that if we could come up with some competencies that everybody agrees to in a comprehensive way, and I think if we could get a commitment from the leading medical institutions, which has been absolutely missing so far, to include these kinds of competencies in medical education, that we would really see a bump forward in the issues. So we have a systemic problem here that isn't solved by our individual education with our individual
That's right.
providers. It has to be solved at a larger institutional level. Institutions like Stanford, for example, have the burden of taking leadership on some of these issues. We've asked you to do this on many, many, many other issues over the years, and this one is really crucially important. We have an aging population that is going to be incredibly in need of the kinds of supports and services and accommodations in the healthcare settings that we've been talking about today. And yet the Institute of Medicine's most recent report, basically says the system is utterly unprepared to handle all of us coming into these years and the ones coming up behind us. So it's really a challenge, I think, to the larger institutions to try to take some steps to resolve the issues.
It's a call for action and also an opportunity to be the leader in this area. And I think we're all just so needed. And we have a few minutes left. So I'd like to open it. Is there any questions? We have about 4 minutes left. So there's somebody with a microphone standing right there. If anybody has a question, we have time for like 1 or 2.
So how can we make medical schools give more education to medical students about disabled people? Because I really think it starts with the medical school model and even bring disabled people into a medical school to talk about their experiences to medical students.
Yeah, so I think that we really need to reach the administrators, people at the school, because obviously constructed curricula, there's always, a fight for real estate, from what I understand from when I was in grad school at UCSF. I mean, even to get a space within a class, a segment on disability is really tough. So it does often start with faculty and the higher ups in the administration. And I think sometimes that has to be a demand by students. Is it be a demand by the community?
I think this also has to be something that's embedded in the testing process, the accreditation, the licensing process, until you start to ask questions on the various exams that people have to pass to be licensed. This is not going to get incorporated fully. That's another element to sort of move the process forward.
Yep. Carrots and sticks. Any question? Other questions?
One in the back.
Just one in the back.
Hi, I'm Joan, and I have a 34-year-old daughter that's developmentally disabled, so I'm really glad to see you all here. But I did also want to let you know I'm at Stanford, and I participated earlier this year in a day on disability in medicine through the School of Medicine, in which there was a panel of people with disabilities and their families who spoke about some of the challenges. And that came about because one of the medical students is a twin to a gentleman with autism. And so he was the catalyst. So I just want to encourage you all that sometimes it takes a long time to get to the administrators. I am one, so I can say that. I can tell blonde jokes and I can talk about administrators. But, a personal commitment, having somebody just really be an advocate. And, he offered to kind of set the whole class up, and he got us all behind him. And you never know who has someone important in their life who is disabled. And so many of those administrators and people who have the power might be really able to relate to one of your stories. So just a word of encouragement and celebration that you're all here today. It's a big step.
Thanks. Well, we have just about 45 seconds, so I feel like I really want to thank Brian and Robin and Mary Lou for being here. And I think there's a lot of, big ideas and big suggestions. I think we can spend a lot in terms of the problems, but I do think that in the future it really does take having the health sciences be more open to having more people with disabilities within, as their students, as their staff, as their faculty, as their administrators. And I think that would really start the change, because when you're actually present and part of the communities, you'll be able to change the environment and the way of thinking. So thank you very much, everyone.
Thank you, Jay.